Yeah.
Okay.
You can see. I guess this
Okay.
is it's in a full picture.
So what do I do? Can I? I'm not so
You
good
put
at.
you already put in presentation, eh?
It's. Let me
It's
see
in
what I have it.
presentation, eh? Yeah.
Is it?
It looks like it's in presentation already.
Okay. I usually have. I do well with Zoom sharing, but in Teams I have still need to learn.
Okay. Try to move to the second slide. Let's see. Second slide. Move
Okay.
just
Okay.
second slide. Yeah, I think it's fine.
Okay.
Yeah, it's okay. Yeah.
Mm-hmm.
Yeah. Okay. I think we can start. I've got the pleasure, colleagues, to um, welcome Dr. Fallah, Dr. Mosoka Fallah from the African CDC. Is one of our outstanding epidemiologists in the continent, focusing mostly on epidemic challenges, preparedness, response, and also building up surveillance system in the continent. And today we'll be speaking to us on a decade of responding to pandemics and epidemics in Africa, the challenges and opportunities that we face. And I'll just briefly, we all have the bio for our speaker today, but I'll briefly just mention that Dr. Fallah is the currently acting director of science and innovation and the program manager for saving lives and livelihood at the Africa Centers for Disease Control and Prevention. And before then, he served as health security technical consultant with the World Bank, where he worked on pandemic diagnostics for the Cabo Verde, for Gambia, Ghana, Liberia, and several other countries. Dr. Fallah has a PhD in immunology, a master's in global health, and many other accolades to his name. And he has championed pandemic response in the continent for quite a while. Dr. Fallah's work at the Africa Centers for Disease Control has actually taken him to many countries in Africa. He has over 100 scientific publications and many scientific reports to his name. So in brief, let me not take too much of our speaker's time, but I've got the honor to welcome our speaker today, Dr. Mosoka Fallah from the African Centers for Disease Control. And so welcome, Dr. Fallah. Let me leave the floor for you. And thanks very much for gracing us with this talk today. Thank you.
Thank you so much, Professor Peter. It's such a great opportunity working with you. You've really been one of our strong resources for the way we move the science and epidemic on the continent. You've always responded to our cause. Thanks for this opportunity. So, colleague, I will try to tell a story over the next few minutes and see what has happened over the last 10 years. So, March of last year was the decade of since we had the Ebola outbreak in West Africa. So a few colleagues and I said, let's sit down and let's sort of write our experiences. You know, we wrote one paper in Lancet and one in New England to say what was it happening. So basically, this is where I want to start and tell this story in a way. So basically, we saw the Ebola outbreak was, you know, for a long time, Ebola was almost always in rural areas, isolated village. These people die out, they don't move to town. But this became a global response. You know, over 11,000 persons died, 28,000 cases, just in 3 countries. And of course, as a result, telling you how connected we are today, from those 3 countries, we have cases spread across the world. It became a global concern. For the first time, we saw the military. But then I was leading the case detection in Liberia, and we were having a big operation center. We had the German, we had many military team deployed to work with us, because indeed it took upon we call the global, it took a security dimension. We know that there was little research, there was no medical countermeasure, and the cases spread. And I share this slide because I was in a meeting with WHO this week, and I was just telling her how vulnerable the continent is. They've been tracking the filoviruses, Ebola and Marburg, since 1975. And with all certainty, it is now known from the data that we should expect one filovirus outbreak every year on average. Last year, we had to face two, Marburg in Rwanda, Marburg in Tanzania, and then by January, we had Ebola Sudan in Uganda. We had to crisscross this. We saw different places. It was sad enough, the Rwandan situation, when we first arrived the next day, many of their senior doctors, specialists, and nurses were dying, because the case got exposed in a treatment unit. It was a sad time to imagine someone specialized after medical school and suddenly their life had to go. So we are vulnerable as a continent. I'm going to go into the data, but I thought I should start with a story so you can understand that when outbreak happens, people die. And this is a story that I'm closely a part of. We're driving in the street, we met this little girl thrown by her family in the street and giving some oral rehydration salts. The family had been wiped out by Ebola, and they were trying to give the girl a chance, and they threw her in the street. And the way was that maybe one of us would see her and give her a chance. And I was traveling that day with a group of journalists, and we stopped. We had to trick out the response team to come. When we went deeper, the whole family had wiped out. The young boy you see there, he was around 6'2", 6'3", an excellent basketballer with a good dream of going to play in the US. Sadly, that family got wiped out. This kid got wiped out. And so when there's outbreak, there are people, there are families. There's this innocent child thrown in the street. You see the people in the PPE clearing members of the family. In this case, I don't have the time to go to the detail, but this case was linked to a clinic, a single clinic where the healthcare workers got exposed, and through that, one of the family members came home and brought death to the family. So when we think outbreak, letting people, real human beings, are affected, families are wiped out, innocent children died. So this clearly state the graph up there is the West African Ebola outbreak, Sierra Leone, Guinea, and Liberia. In rare is Liberia. There was a point in time by September, Liberia was accounting for 50% of the cases, followed by Sierra Leone. We had an abrupt end when Guinea had a long stretch. But come back in 2022, when Ebola Zaire ended, we're part of the discussing on the lack of vaccines and treatment. We would discuss that we knew that we had made some progress with vaccines and treatment for Ebola Zaire, but we were not succeeding in Ebola Sudan. So we started making noise and said, we need to start preparing. 8 years later, Ebola Sudan happened in Uganda. There was no vaccine. There were no medical countermeasure. When the vaccine arrived in the country, it was already late. So the same story repeated itself 8 years later. The continent is vulnerable, but the continent is unprepared for outbreak. Now, I want to zero in on the West Africa outbreak. I don't know if my slides allow enough, but the message of this slide is that there was a point in time, probably October, when it was declared by WHO and US CDC that if we did not continue the outbreak, about 1.4 million people would die. I have a colleague of mine who had traveled to India to learn cremation because they had told them that there will be no way for us to bury the dead. So we have to cremate all of our deaths. So they set up to cremate the dead. That was the kind of bleak feature we had. These were some of the predictions they made. The doubling time at the time was every 20 days. Well, the cases were doubling every 20 days. I remember talking to my friend from MSS saying to me, Mosoka, take care of yourself because now we don't know if we are going to be safe. All of us are in danger. At the end of the day, this graph tells the picture. You see, if you look at the map, the diffuse spread of the outbreak across the continent, across those 3 countries, the case fatality rate, you see there, almost 70% was the case fatality rate. At the end of the day, we couldn't save 11,300 persons. Thousands of orphans were left with us to manage because of that outbreak. With all the death predictions, this is me, because I grew up in the slum, this is me going back to my slum and trying to work with local people to be able to reverse the outbreak. Once they made a prediction of 1.4 million dead, someone decided to go and change the whole mindset of the people to educate the community and say, we have to change this. We had to, even though we had all the sophistication and the science, but it was critical to have people to understand the outbreak. And you see, as we progress, immediately after Ebola ended, I joined a couple of international guests for us to take a look at what went wrong with the 2014 Ebola outbreak. Some notable faces are there. Today you have Mohammed Pati, who is now the Federal Minister of Health of Nigeria, Shah Ashid, who was working with Biden, and a few others. We met in Boston, in the UK, to consult and say what really went wrong. This outbreak really feel so many people die. And so as a result of that, we published a paper in Lancet. It was the group organized by Harvard and the London School to say what really went wrong. And essentially, we tried to piece out exactly what went wrong across 4 different scenarios. As you can see, there was just inadequate preparation. There was inadequate monitoring of the events. In fact, I quite remember there was inadequate incentive. I quite remember in Liberia, there were 2 ambulances to cater for all of the outbreaks. So, and then there was 1 card for dead bodies. If the car left the city and went to pick up dead body out of town, the rest of the bodies would be in the house. Family would stay with the bodies in the house, and there'll be no way to pick them up. So we also saw that there was later incentive for early reporting, which was very, very necessary. Even though we had the RHR, but we realized that it was the reporting system at the time was very, very, very vertical. A guy in Liberia will have to report to Geneva before Geneva informed Guinea. It was not horizontal across countries. So essentially, we said that given there were this failure at all levels, even within the continental organization, responding was low. The RHR capacity was not applied. Essentially, we should have given support to these countries. These countries had gone through war, and obviously, they were not prepared. So most of the time, the worst situation in any outbreak is at the pre-outbreak time. It's going to be the investment you make in the pre-outbreak. Essentially, the pre-outbreak investment was limited. Countries were not incentivized. They were limited human capacity to invest in the response. I'm just saying that over. So we say across all 4 phases, there were weaknesses. WHO alerted early, people responded later. I hate to say this, I don't want to discourage some of our guests, but one few of us were in the field, other people were in this very fabulous hotel, having meeting and said they were in Liberia to support the response, but they were in the big hotels enjoying themselves, while few of us limited resources, limited knowledge to help the outbreak. So essentially, it engulfed the world. So afterwards, we suggested that there should be some reform, that there should be a major reform in the pre-outbreak era. There should be, when we're responding to outbreak, and there should be an investment in research, that we need to look at the whole governance system, or that there was a major problem that was wrong. So essentially, we said we needed to develop a global system to be able to monitor outbreak. We needed to strengthen and incentivize countries, because the Ebola taught us one key lesson, that if you don't incentivize a country, that the isolated spot of today become the hotspot of tomorrow. So we shall incentivize country. We went a little bit further and said we needed a uniform structure. We asked for an emergency response team for the WHO. The WHO needed to do better to create an emergency response team so that it could be streamlined in the event of reporting of events of international concern. They should respond very quickly. And by the way, and we also spoke about research. Obviously, when the outbreak started, there were no medical countermeasure. There were no research on the social behavior influences of people. The Ebola affects culture, it affects society. In the African culture, you take care of the sick, you take care of the dead. But Ebola is saying, don't do that. How do we reverse that cultural in a way that will make it safe and dignified? So we ask for research and we ask for reform in the governing the global system. When this report was coming out, a colleague of mine called me from WHO and said to me, Mosoka, we've heard that you guys are coming up with WHO reform. Can you? I said, no, we have embargoed the article. We cannot release it. So it came out together with many other reports to say, no, there was a failure in the system from the weakened country level, at the country level, from the weak public health system to the coordinating body at the continental and global level, and that there was a need for changes. So two major changes happened that I want to speak because I spoke about opportunity and challenges. The two major changes that happened, and I will speak to them in detail, was that WHO decided to do a major reform from the lesson. The second important thing that happened was that those that want to assist with the Ebola outbreak from the African Union, and based on the meeting of the heads of state, decided to launch the Africa CDC. Two critical results from the 2014-2015 Ebola outbreak that devastated life and affected the world. So obviously, as you can see in our recommendation, we asked for the formation of a specific department on emergency response. The WHO immediately streamlined itself and created an emergency response office in Geneva and at the various regional offices. That there should be a rapid deployment force like an emergency response workforce. That has happened many times. I have been in many countries within 24 to 48 hours after an outbreak. I see the WHO team on the ground with us. We needed to streamline the procedure. The WHO decided to streamline its procedure to reduce, and then also to have contingency fund that can be available within 24 to 48 hours if there was an outbreak. They went increase the budget side of the WHO and decided to relook at the IHR 2005. As we said to you earlier, one of the weaknesses in those countries was the notification and the ability to help countries to move forward was very weak. And so the IHR decided to be reformed to help us to detect cases. Then, of course, the WHO introduced the joint external evaluation. And that became very critical, as I don't know how many persons have experience with the JE, but you had to look at the whole public health system, the preparedness and response system around different dimensions. That was introduced. And then there was a single program approach. So essentially, the WHO was able to do internal reform as a result of the outbreak. In Africa CDC was a concept that was launched in Nigeria before 2014. The idea was we needed a continental organization to help us respond. But when the Ebola outbreak started and the cases were increasing and the continent was threatened, there was no body to do that, no organ. And so what they did, they formed a sort of loose team and got funding from the disaster response that was used to deploy this team into Liberia, Sierra Leone, Guinea. And many of them work with me, and many of them are my friends. That's how I actually ended up at Africa CDC. I remember the day, this particular day was October or November, and I was walking to the Ministry of Health, and I saw almost 50 cars from the Africa CDC team, the African Union team driving out. Hello? And I was crying because I wish they had come 3 months earlier. We would have saved a lot of lives. But the lesson from there was Africa CDC got created. And I won't go through this. You can read the slide. With the mandate to be the technical organ for health security for the continent. It will do its work through the various regions and will work through member states. So it created all of these framework that I'll let you take your time to review. But the take-home message is that Africa CDC was formed, WHO got reformed, and the next good news I want to share this slide that is very informative was that they needed to create National Public Health Institute, like what we call the US CDC. This will be agency that will be the one that will lead the early warning, early detection. If you look at the slide, earlier there were only a few countries, the green countries are come to the Public Health Institute. And one of the mandates of Africa CDC is to ensure that all countries develop Public Health Institute. As you can see right now in the green and yellow, green are countries with fully functional National Public Health Institute. The ones in yellow are the ones that are already starting some form of institute. So those two things became the greatest silver linings from the outbreak. But I want to ask here, after we made a reform from 2014, did that help us to do a better job? I will let you be the judge. 2018 to 2020, there were Ebola outbreak in the DRC. We got involved in the outbreak. At the end of the outbreak, you look at the numbers. The outbreak lasted 2 years, just like the one that happened in West Africa. The outbreak took an international spread from DRC and went over to Uganda. There was high mortality. The case fatality rate was 65.9. As you know, the one in West Africa, even though it had more people, it was 70%. So we are saying that right after the Ebola outbreak in West Africa, we made reform and changes. And then we saw that 4 years later, we had an outbreak in the DRC. But we had increased fatality, increased cases, a replica of the 2014 failure. What were unique for the DRC? So these are some of the papers we published, using our experience to inform the world. We leave this for people who want to slap. And then this is the president. I have just come back from Goma in the DRC and wrote an article when President Tshisekedi had taken over to say how he could help to reform the response in the DRC if we're going to end the outbreak. And one of the things we noticed that most of these outbreaks are driven by poverty, and we wrote an article about that. But the key lesson was that why is it we fail in DRC? The outbreak was just one of several emergencies. There was war going on, and so this one became one of several. People did not trust the response team. The treatment was limited. There was no treatment. As a result, people left from rural area and came to city. Patients were not respected as we wanted them. There were no medical countermeasures, just like 2014. Because there were war in the east of DRC, therefore there were heavy security presence. There were some of my colleagues who would move around in bulletproof cars. Some of my colleagues were sadly killed in the DRC, Ituri. And we saw that many of the healthcare workers got infected. We saw that there were pre-outbreak poverty and reduction in basic services that led to distrust. There was so much distrust. There was the mafia group called Mau Mau that were hunting us, the response worker. And so all of these factors now told us that Ebola is not only a health system issue, it is a cultural, political dimension that even if you manage the public health system, if you don't manage the public health system dimension, you will have a problem. Are you hearing me? Am I audible? So the first case, we say that we may reform, but the Ebola in DRC, we feel we did not do well. We have similar results. Now, let's look at Guinea, one of the countries that suffered from the outbreak, the Ebola outbreak. In 2021, Guinea reported a new Ebola case. Let's do a deep dive and see if the investment done in the country and the reform at the level of WHO. Hello, can you hear me? I lost my slide.
Yeah, I can hear you. You have to reshare the slides.
Yeah, I know. Sorry. Oh. Can you let me know if I'm going very fast? Okay, so that I can slow down a bit.
Yeah, you can keep moving them forward.
Okay, good. Forgive me, colleagues. I think we have a little bit of internet issue here.
Yeah, no, it's okay. It's okay. These technical things.
So then the outbreak started in Guinea, and we see that unlike DRC, where there was a failure that were not only related to the public health system, but there was a failure because of political factors, war and all of that. Now in Guinea, this is the outbreak. This is the epidemic in Guinea, over the weeks. And then let's do a deep dive in Guinea. So at the end of the outbreak, the three countries, there were massive investment in the countries to prepare them, looking across the health system. And we are looking at Guinea. You see two maps there. What the map shows you there is that if you look at the lower map, this is the 2021 Ebola case, around 7 years after the major outbreak. The upper map show you that of the 38 districts in Guinea, 36 of them had the disease spread. So there was no containment, which is worrisome. But in 2021, they kept the outbreak just where it started, from where it was elected. It was kept there, it did not spread further. So this seemed to be a major improvement as a result of the investment in Guinea. Now, if you look across the epicurve, you see that there are around 25 cases, and you see the number of cases reported per day in the 2014 Ebola outbreak compared to the one that happened in 2021. Was it by accident, or there was some investment that paid off in 2021? If you look at the map, from the time the case was suspected to the time the case was reported, I don't know how many persons followed the case, but it's an intricate way to see how outbreak lead from rural areas to urban. The sick person traveled all the way to Gegedu and to the capital city, Conakry, and they infected people along the way. It took 3 months for the first case to be reported from the time the potential cluster of death was happening, and you will not believe this. In that case, the sample had to be collected and sent to France to be tested and the result to come. When Liberia detected its case, we had to go across the river, use canoe, and move the sample to Guinea. So there was the time lag between detection and even reporting and confirmation was 3 months. And in rapidly spreading epidemic, timing is everything. We go back to local 2021. In 2021, from the alert to the confirmation, 2 weeks. So you can see there. Now, with this investment in Guinea, with the reform, we see that the timing has shrunk dramatically. I create this table to look at just a comparison between the 2014 and 2021. You can see, if you look at before we could even get medical countermeasure, 1 year before we could even get experimental vaccines. Whereas in the Guinea outbreak, there was not only a vaccine in 1 week, but there were 2 therapeutics. You might imagine 3 months to 2 weeks. If you can look at the spread, you see the spread across district. You look at the case fatality rate, 62 to almost half of it if you look at the confirmed cases. The most important one, you look at the investment in money. It is reported that for the 3 countries, the total money expended was around $6.7 billion for the outbreak, $6.7 billion. My country, Liberia alone, was $2.5 billion was spent in Liberia for the outbreak. Liberia annual budget for health is $100 million. It means that the fund we need for 22 years was expended in a matter of 2 years. And then for the outbreak in Guinea, $45 million. So with this investment in the country and the reform, we saw that there was a containment, right? And was it accidental? No. I share with you before the outbreak happens. So One Health was put in place. The structure was decentralized. They did a risk assessment. They developed the public health workforce and decided to get involved with the communities through community health workers. Now, at the level of the outbreak, the Emergency Operations Center was established. There was an early warning system that was not available during the 2014 outbreak. And so whenever you have an outbreak in one area, what you do is that the areas that are at risk, you begin to prepare those areas to detect. Those were measures that were put in place. And even after the outbreak ended, they had 90 days of enhanced surveillance. So it really tells you from a scientific point of view that if you invest in the public health workforce, emergency operations center, a national public health institute, in early warning system, you can, one, reduce the severity of the disease, the mortality. Two, you can reduce it's economically effective. So indeed, it works. But I have a big but. Remember, we said if you invest in the public health system, what happened to Guinea later on? COVID-19 in Guinea. COVID-19 in Guinea, the same country that did well in 2021. This author compared the COVID-19 cases in Guinea, Sierra Leone, and Liberia, the same three countries that were affected by Ebola. And Guinea was performing very, very poorly. I will show you now here. Those are the cases in Guinea compared to Liberia and Sierra Leone. So what does that tell us? Now, they did a comparison again among the French-speaking countries, Guinea, Burkina Faso, Senegal, and Mali. You begin to see that Guinea was sort of leading the number of cases. How can this country that has done well in a recurrent of the recall Ebola perform so poorly in COVID-19? Basically, there was inefficiency. There was an issue of the biology of the outbreak. There was this confidence that everybody could respond because it was Ebola, but the biology of the two diseases were different. This one could spread very fast as it was a droplet. It was spread through respiratory means. But most important, there was a big distrust of the government. Secondly, there was an election year. There were poor political decisions made. The investment that were made for Ebola was not sustainable because they were done by experts, foreign experts, and not having local ownership. It was an election year. The government was reluctant to communicate. Coming back to the DRC scenario, public health investment alone is not enough. One needs to manage the politics and the government institutions. So Guinea did well in 2021 in Ebola, but when it came to COVID-19, it was the worst performing country in West Africa. So community trust is critical. Government investment is critical. Building a strong political system is critical. And one of the things we learned from our work in Rwanda, in COVID-19, Rwanda and Morocco were our center of excellence. By the time we arrived in Rwanda in December of 2021, Kigali had vaccinated for 95% of its population. Rwanda they have a social welfare system for the elderly. They use that database to find the elderly and to vaccinate them. So welfare, addressing poverty issue is critical when there is an outbreak because then there is a trust in the system and the government. Very, very critical that the political dimension, the trust of the community can decide the outcome of the outbreak, no matter how much we invest in the public health system. Then we all know what happened with Ebola. We did not get vaccine on time. There was a distrust in the vaccine when they came late. We all know the problem, the issue of vaccine nationalism. Some countries had enough vaccine stockpile to vaccinate themselves 5 times. When African was struggling, there were predictions that we're going to die. But then by the time vaccine came, people were using it for diplomacy, for power. So therefore, certain vaccine from China will go to certain countries, certain vaccine from Russia will go to another country. And Africa itself has not developed yet a regulatory system to be able to track donated vaccines. The cultural norms that govern vaccine acceptance, misinformation, all of those, and then our inability to manufacture our own vaccines and medical countermeasure. So essentially, we show that we reform this system, but there are other issues that must be addressed for us to be able to encounter the next outbreak and resolve it. Yes, there are opportunities. WHO has been reformed and doing a better job. Africa CDC is formed, has presence in multiple countries, but there are other issues that we must go on. But we clearly have shown that investment in early warning, investment in public health workforce indeed has a positive impact. I want to just close up quickly and take question. The ongoing Mpox outbreak. when mpox was declared as a public emergency of continental security, we were among the first group deployed to the DRC. Peter, just highlight me if you want me to close. I can close, please.
No, you are okay. You are okay on time.
Okay. We got to DRC, we're in 13 countries, but now we are now in 23 countries. The cases continue to spread. We still have challenges. There's massive cross-border spreading. The science of the mpox is still a challenge for us as Africans. I tend to show this slide to tell a story that we as Africans are good that we are scholars here in the global community. Mpox is not a new disease. It has been around 50 years. This is for people that were published from Cameroon. It has been around for 4 years. It is sad to note that up to now, we don't have any therapeutics for mpox. There's no treatment for mpox. It is sad to note that the vaccine we have was meant for smallpox. We are repurposing it now for mpox. Not only that, but the global stockpile of mpox is a challenge. We managed to have distributed through Africa CDC around 30 million doses of mpox vaccine, 1.5 million, about 1.5 million through the Bavarian Nordic MVA vaccine, through multiple channel donation to the US government, EU HERA, and then 1.5 million doses of the LC16, a bilateral donation from Japan to the DRC. Even at this stage, we have a serious lack of vaccines. I was in Uganda the last time speaking to the incident manager. In order to rapidly contain the outbreak for a single dose, they will need 2.5 million doses. For double dose, they will need 5 million doses. But we don't have any vaccines right now. The vaccine in stockpile is going to cost over $33 million. It's with Bavarian Nordic. So we see, 2014, we had challenges with vaccines and therapeutics. We made some improvement with the Ebola Zaire. We did not make improvement with Ebola Sudan. We have not made improvement with other vaccines that are critical. And I clearly show in my earlier slide that the continent, because of climate change and travel, is becoming more vulnerable to outbreak all the time. And if you can see here, almost all the major outbreaks that threaten us, we have limited medical countermeasures for them. As you may be aware, there is an emerging threat right now, the threat of chikungunya. We started first with Mauritius and Reunion. Now we have cases confirmed in Kenya, in Madagascar, and other countries, and continue to spread. The sad thing, there's no vaccines. We've been working in discussion with Vanova to see if we can, their vaccine has been approved by the EMA and FDA, but not for Africa. We're trying to launch a study. So all the threats we face as a continent, we are not able to address the vaccine issue. So there are three key messages I want to share here over the last 10 years. Poor, weak public health system and workforce and laboratory system makes a country vulnerable to the devastation of pandemic and epidemics. But those ones can also spread as one. The political and social dimension, the issue of poverty, economic dimension of outbreak of the citizen must be considered if we be in position to manage outbreak. The third message I want to convey is that Africa, 1.4 billion people, China, 1.4 billion people, India, 1.4 billion people. China is the second largest producer of pharmaceuticals, followed by India. Africa, 1.4 billion, import 99% of its vaccines, 95% of its diagnostics. So we get three factors affecting us with outbreak: investment in public health, political, poverty, and social issues, and now our inability to invest in medical countermeasures. So basically, this is where we stand. To share with you my journey in being in part of this outbreak over the last 10 years. Many of you may have been involved with this, but indeed we still have a long way to go. We have these three critical factors. We need to address them. We have big opportunities now, I have to admit. One, the Africa CDC that is able to deploy team, WHO reform. The most important development since last year was that WHO and Africa CDC now co-lead outbreak on the continent through what we created called the Continental Incident Management Support System. So we are now working together with all partners to consolidate and move outbreak. But as you can see, whatever gains we made, they are fragile. They can be disrupted at any time when the proper variables are not together. So thank you for the opportunity. I hope I did not run through the slides. I was afraid. I want to give time to take questions. So you be the judge where we stand right now. What do we need to do and the role that each of us need to play in making this continent better prepared for next time. Thank you very much.
Thank you very much, Dr. Fallah. Thank you. This has been very enlightening to most of us. Great getting a broader continental view of epidemics, pandemics, and responses, key challenges, key areas we succeeded, and the potential suggestions for what can be done. So this has been very enlightening. Questions from the floor? Anyone who wants to ask any question? Yes, Z, you can go ahead.
Yeah, thanks, Peter, for the opportunity, and thanks to Dr. Fallah for the quite eye-opening session. I think I agree with you generally that we will continue to see more outbreaks due to population growth, coupled with, I suppose, ecological shifts where we're seeing zoonotic spillovers. So I think essentially in COVID-19, we got to understand the diagnostic challenges basically, and then we saw a lot of molecular and genomic investments, particularly with support of funders. So my question here essentially is, these infrastructural investments we saw, molecular and genomic investments, they can vanish, or they could be dismantled in a few years as the equipment gets older, or it's not used, or it's not replaced, or the funding for reagents is getting finished or dries up, and many trained scientists can immigrate to the global north. And I'm wondering, how is Africa CDC supporting or engaging most of these low and middle income countries, particularly to ensure that this infrastructure and expertise have ongoing benefits? And I think we know the ongoing fluctuating funding challenges. So the question being basically, we don't want to be caught unprepared, as you mentioned from your first few slides. How is Africa CDC working on this? Thanks.
Thank you very much. I don't know, I can take one or two before I respond, or can go ahead and respond to this. Actually, this is a very brilliant question. And it's timely. Actually, the entire week, there has been a team of African scientists, diagnosticians here in Addis Ababa. Africa CDC launched what we call the Panther Network. So as you may be aware, during the COVID-19, we have 2 countries with sequencing. We invested a lot of money, and then we have 40 countries now. But what Africa CDC had done through our Center for Laboratory is to create what we call the Pathogen Genomic Initiative, a common pool of funds for 3 main goals. One of them was to first provide training, extensive continuous training, almost every time there is training here. Harness resources by pooling resources together and supporting to set up the molecular diagnostics, the reagent. But the feature for that is that because you're coming to pooling, if you become a part of the PGI, you will be able to get reagent in the future after the funding goes out at 25 to 50% discount by pooling together the countries. In fact, we just submitted a paper for publication. Now we are looking at AI because we did a survey and realized that AI is limited. And so we're trying to say we can bring AI as a new tool in the country. So yes, we are very cognizant of that. Training is ongoing, initiatives are launched, but the nitty-gritty is that some of these funding, eventually the country have to find ways to do domestic financing. You all know it, I can be certain. We now have goodwill. We have funding from the MasterCard Foundation. We are in 40 countries, we're investing, and the EU has given us some funding. But honestly, we need to, at the end of the day, countries need to invest. Countries need to invest and own some of this. We have a project with Makerere University. We are looking at reimagining health system. It's a big project we're trying to put together. Peter will discuss that more. later. But basically, we're saying that even if you look within the health system, if you look at wastage and leakages, there are so much that can be saved and repurposed towards these things. It is said that 40% of all the investment in our health system goes up because of leakages. 37% of we lose because of absenteeism of health workers. It also shows that we are spending 5 to 17 times more on drugs in Africa, above the market rate. So we need to reform the health system so we can start to own and invest in some of these. Thank you so much.
Thank you. And Dr. Musa, go ahead.
Yeah, thank you very much, Dr. Mosoka, for this very interesting presentation. And thank you also for Professor Nyasulu for setting up these really interesting talks. Doc, I know that there was a lot of efforts in vaccine development during and after the epidemic of Ebola epidemic. Where are we right now with the effectiveness of those vaccines, the availability to our countries, and potentially what is the contribution of the vaccines in epidemic preparedness and control for Ebola right now?
Thank you so much. So for the first time in an outbreak, what we've done is that Africa CDC is leading and coordinating all research on the continent, from therapeutics to vaccines. We are tracking all 48 research. That was the first thing. In the 2014-2015 Ebola outbreak, we have parachutes. People come and parachute, take our specimen and go our routes. In 2 weeks' time, we're having what we call the research stock taking to look at all of the research ongoing on Mpox and how those research will be able to feed and support our response. Having said that, currently within the research, Africa CDC is working with Panther to launch the only antiviral therapeutic trial, clinical trial. We started in the DRC. We are moving now to Uganda and Sierra Leone soon. We just completed the protocol for the vaccine effectiveness study for the MVA vaccines. So I didn't have the time to go into details to the next step. But one of the critical things that's happening now is that research has become a critical response pillar. This was not seen in 2014. Now research is a critical pillar. I have a colleague from WHO that co-lead the research pillar, working with researchers across the continent for different research, working with each other, coordinating together so that we can learn lessons. Because the critical thing for a research during outbreak, you reduce the transmission, you avert the mortality, or you prepare for the next outbreak. That's one. So we're using the opportunity. Secondly, which we are engaging, we need to invest into clinical trial and preclinical research. It is a weakness Africa has. From the basic discovery science, one of the areas we are looking at, honestly, is South Africa and Egypt to very, very play leadership role in the area of discovery science and preclinical research that will lay the basis for vaccines and therapeutic. We have extreme weaknesses. You will notice that what happened to us in Africa is that people bring us phase 2 and phase 3 trial. Even though we have a diverse genetics, our response will be different. We need to basically get involved. Really, that's why you see us developing a strategic plan, harnessing the diaspora, which you are part of, working to be able to get African scientists. And I can tell you for free, it is not because we lack ability and talent on the continent. What we don't do well, we don't network this talent and ability. And that's why people like you, myself, Peter, are networking, bringing the universities together, the research institute. We need to do this. We are very vulnerable. Nobody is going to invest in us for us to do vaccines. I can tell you for free, I don't know how many of you know this, there is a big TB vaccine, new TB vaccine on trial going, phase 3. Guess what? The bigger hands that are funding the trial will send it, after we get a clinical trial done, there are 6 countries, 5 of them are in Africa. The vaccine will be manufactured in India. It will come to Africa for fill and finish. And you know what that means. So we got work to do. We have to accelerate. We have to work too hard, come together as a group, harness some of the research capacity that institutions are still very hard for discovery science. We need to work hard. That's why I can say we really need to work hard. Yeah.
Thanks, Dr. Wasuma. You can go ahead.
Thank you very much, Professor Nyasulu, for this invitation. to attend this webinar. I'm really very, very, very happy and impressed by Professor Dr. Mosoka. Thank you for this very insightful presentation. And I like the way you told the story and spoke from the heart. And I know you're very passionate about what you're doing. And I think I just want to make the comment that the best thing that happened to us in Africa is Africa CDC, because they've really taken their rightful place, taken leadership in Africa in terms of coordinating and prioritizing even research and innovation in Africa. And I think that we as Africans, we really need to pull behind Africa CDC so that they can continue to speak for us and get us moving together, because we really go fast and far together. But I like just to ask one question. You said that we have inability to invest in countermeasures. I think that to some extent there's a political will, and now we need political action. What is it that holding our political leadership in really putting resources to where they have said they would want to put resources? How can we as citizens help them to move forward?
Let me take this question that Monique has asked. It's so critical. I think we are to be blamed from the beginning, and I will tell you why. The way we have done research in Africa before has been, one, to publish paper. Two, we don't carry the politician along. We think that they're not important. How many of us, before we launch our research, will go to the politician and say to them and say, we want to launch this research? That's the first thing. We haven't done good. Our advocacy to politicians has not been good. The other part is that politicians understand the language of economics. How many times have we gone to the politician and tell them, if you help us to reduce this NTD, you are going to save $20 million per year, and you can now put that money for schools? So I think we have a problem. We need to work harder on it. Yes, because I just left DRC. I was to leave on a Saturday. The Minister of Science and Technology said, no, you got to stay because we want to launch a new trial, and I want to have dinner with you. The same thing with Monique, the Minister of Science in Uganda. The same thing here in Ethiopia. We need to shift the paradigm. For that political action, we need to win them on our side, advocate to them. That's why we are planning, hopefully, a big meeting this year, hopefully, if all goes well, in Angola, to see if the president can help us to host this meeting with leaders, some leaders and ministers, so we can ready. So basically, we need to change our strategy. Whether we let them, they are the ones that make decisions. We need to bring them on our side, and we need to help them to argue. The argument we give to them, they have to see the economic benefit. I know 10 people, okay, you will save 10 lives. It's okay. We know that, but for them, they want to see the economic value. So we need to come together and take one aspect of our goal to put a group together, like a think tank, on how for us to advocate to change from political will to political action. This is so, so important for us, and we have not done a good job. All of us, we want to be publishing in Lancet. It doesn't matter to those people, even the community people. They want to know how our research will benefit them. So I think we need to do a better job. We've done a bad job, all of us.
Thank you. Thank you.
Well spoken. Thank you. Thank you.
Thank you. Thank you very much. Linus, you had the hand up.
All right, thank you for the opportunity. Most of what I wanted to ask was already asked by Monique. That's why I dropped the hand. But maybe I can just add on the question that she posed. Mine was really leaning towards African CDC interventions that were put in place or that we have actually implemented in Africa as a whole. In trying to advocate for all these interventions that we would like, even the vaccinations. Have we had a chance to present these issues maybe to the AU or other bigger platforms that Africa can be united in trying to put in place interventions for our own public health concerns? Because if we import interventions, we also import the concerns. They put forward their concerns for us, and we don't have that chance to intervene for our own health issues. So I don't know if African CDC has had that opportunity or that chance to advocate at that level, but I understand it's at all levels that we need to do all this advocacy. Thank you.
You raised two key issues. So we have this issue called local manufacturing agenda, but the way our people from the global north are seeing this, local manufacturing for them is tech transfer, drug substance, so it's made somewhere else and it comes to us, like you said correctly. Once those solutions are made elsewhere, they will not speak to our context. We need to start from the fundamentals. I'm praying that we can really network a lot with Africans who are doing very well doing research so they can come and use their knowledge. Like the project we're talking about, DRC, is a Congolese scientists have developed an antiviral and an anti-cancer. Now we're trying to link in with Tanzania National Institute of Medical Research for the preclinical trial. We need to build this network to think our own solution. We really need to find more time so we can meet and we discuss as African. Yes, otherwise, any imported solution will not be our context. Platform, we've started doing this. We brought, first thing we brought the, science directory is about a year or so old. We've brought the first time 130 scientists regulator to Addis, just scientists, and now we are putting them into different categories to look at the problems of Africa. The second thing we had is launching with few ministers, some ambassadors. Monique was there. We also had a meeting recently in Kigali with a section. We are planning a concept now has been developed for this coming UN General Assembly. We'll let you guys know more and more. We developed a concept that was submitted because we know our political leaders will be there. We want to have a section black at the UN General Assembly so that we can speak to our leaders and international leaders. But we need all of us to co-create the messaging we want to share. And then, of course, we are working with the AU chair, who is the president of Angola. We're really working with him to see if he can help us before his tenure end to call a meeting in Luanda. It's really one of the projects we are really working on. We want all hands on deck. Yes. So please help us. Let's create the channel. If you have your connections in your country, your minister, let's do that. We know that the Minister of Science and Technology of Uganda wants us to have a meeting on natural therapeutics. We are working with African scientists, but please, we're young as a director, but we want a lot of heads together. Let's move with the passion that Africa got to find its own solution. And yes, so if you have some thoughts, idea, please. We practice open policy. I can ask Peter to put up my WhatsApp. Anytime. I'm so open to new ideas so that we can network to solve our problem.
Thank you very much. Thank you for that. Any other question? Dr. Fallah, I was just wondering, the monkeypox is an odd story, but why did it become a real problem only now?
We think maybe mutation very interestingly, because the clade 1 started, the clade 1A, which is believed to be zoonotic, then it went to clade 2, 1B, and I think because the neglect over time, it circulated a lot among people and probably genetic pressure, and then they just have some mutation because it started some time ago. Started hearing about the clade 1A among the minors, and in the mining section. Then we talk about the sexual transmission. Attention was not paid. Then it spread to Central Africa from DRC. That's one. Even the recent spread we see in West Africa. Some colleagues did some work and said there is they call it clade 2BG1 submutant that was responsible for the spread from Nigeria. It seemed to be the one circulating in West Africa. So basically, we have more people exposed, no treatment, no control over a period of time, and mutation have driven it. We know in Africa, the sexual workers are one of the major drivers in some countries. We know that the corridor where there are movement of trucks is driving it. And I think we have not understood the science too well. We need to come together to understand the biology, the epidemiology more and more. We got some protocol we're working on to look at sequence data compared to disease severity. We just did draft 1, but we need to come together. That's all I can say. I think it's a neglect. It's spread a lot. less attention was paid to it. Mutation started and other human behavior and factors. I think one of our colleagues spoke about the epidemiological shift and it became more prevalent. Last week, we had a case in Cameroon in a family, an area that is used to bush meat, hunting and eating. There is no history of imported case. So we think it's that, but overall, essentially, we need to let the science to draft. The science need to draft the preparedness and response for our countries. If we neglect it, our people become vulnerable and many persons die. That's what I can say.
Thank you very much. I think we've gone beyond the time. I know colleagues have a lot of questions they may want to ask, but every good thing must come to an end, I guess. Thanks very much, Dr. Fallah, for your time, and thanks everybody in who participated and attended. I really appreciate, and yeah, we invite you again to our next seminar, that will happen in the next couple of weeks, and Chanel will always communicate. So please feel free to patronize. Thanks once again, and thanks, Dr. Fallah, and everyone, have a good day.
Thank you so much. Let's keep in touch, please. Let's keep in touch with the ideas. Let's build this continent together. Science on this continent. Thank you.
Thank you very much.
Thank you.
Thank you.
Bye-bye. Thank you. Bye.
Bye.